Doing okay. How are you?
I'm doing good. So, what's your name?
My name is Trace.
How old are you?
21.
Okay, and what sport do you play?
I play football, a lineman.
Oh, okay. So what happened here? What's hurting you?
My shoulders just hurt during practice, and so I came in here.
Okay, so is your practice over? When did it happen?
Practice is still going on, I think, but it happened like 30 minutes ago or so.
Okay, so you came directly out, no
Yeah.
return to play.
No.
All right. So can you tell me a little bit about what happened, how you injured it, when you first noticed?
Yeah, we were doing this one drill where I had to block my teammate, and running back was running behind me, and so he ran to the right side, and so my teammate kind of like shifted his body toward my inside of my body, and I had to shift for that, and so I shifted to the left, and my arm was caught in like this weird position, and I just like felt this like really bad pain, and so I just went out.
Okay, so basically your arm was kind of
Yeah, it was out. Yeah.
out
Yeah.
externally, like you were rotating.
Yeah.
Okay. All right. So on a scale of 1 to 10, 10 being like the most pain you've ever had, and 1 being like not that much pain.
Mm-hmm.
How much pain are you in?
I'd say about an 8. Yeah, that's it.
Okay. And 8. Have you ever injured the shoulder before?
No. I just normally have a little bit of like weakness in the shoulder compared to my other one, but
Okay.
other than that, no injuries.
Weakness when doing what? Like performing what kind of movement?
I mean, like pretty much any movement. Like in my left one, I could do this one. I'm much stronger on this shoulder than I am this shoulder, just overall.
Okay. And your external movement?
It's not great.
Okay. Did you hear any like weird sensations or abnormal sensations or sounds?
I heard a pop.
All right. All right. So let me just take a look at what we have here. So we're doing an observation. We see that our patient is externally rotated and he's guarding his arm. So that's something that you want to look for. However, the patient comes off the field or comes into the training room, and then he complained about anterior shoulder pain. So we're just gonna look at his shoulder for any swelling. In the shoulder, there won't be too much swelling because it's like a wide range of where the swelling can go. So we will see some swelling, not that much, maybe echymosis later on. But what we're mainly looking at is if there's any obvious deformities. There's an obvious deformity right here. Basically, it's going to be in between his acromion and like the greater tuberosity. So we do see a deformity, and then we're looking at his face about how much pain he's in, because he's in severe pain when he first came in. Because I saw the obvious deformity in his, like right between his acromion and the greater tuberosity of the humeral, I already know that it's an anterior dislocation. So if you know that it's an anterior dislocation, you can check distal pulse and also sensation, split, and refer if you don't have standing orders from a physician that you can reduce the dislocation. So if there's not an obvious deformity, because sometimes there isn't an obvious deformity and it can be, it can lead you to think that it's a different injury of the shoulder, or you just can't see the obvious deformity because the player has equipment on, then you can start palpation. When palpating, we want to basically fill all the bony landmarks of his clavicle and his scapula. So I'm going to start off where his jugular notch is, and then I'm going to palpate each spot and ask him if there's any pain. Anything? All right? And I'm just gonna keep on going up his clavicle, and then I'm gonna find the medial border of the scapula with my other hand, go up to the spine of the scapula, and keep on palpating, keep on asking if there's any pain until we get to the AC joint. Is there any pain there? No? Okay. So then eventually we're going to get to the humerus, and we're going to get right above the chromion, and then we're going to get right next to the greater tubercle of the humerus, and we're going to feel that deformation or the deformity. Right, and that's basically the humerus is not in the glenoid cavity, and it's popping out forward. Yeah. So for palpation, after we feel that deformity, again we can splint and refer and check for distal pulse and sensation, and then if we decide to go another route and we decide that we are gonna reduce his dislocation because we have standing orders from a physician. From a physician, what we're gonna do is give him some traction, and we're gonna rotate his arm from being external to internal, right? And then we're gonna release on the traction. So let's see. So we're gonna hold on traction and then internally rotate him and then release, and that's how you would reduce an anterior dislocation. The patient should be very relaxed when doing that, so you'll be able to reduce it. Okay, so we've reduced his anterior dislocation. So in my opinion, after I reduced a dislocation, I would immediately just put ice on it and sit him out for the rest of the game and get him some imaging, because what we have to be careful of, especially when we have a dislocation, the reason why we don't have the study, it's not in our scope of study to reduce certain dislocations is because we have to be careful of fractures. We have to be careful that the rotator cuff or the secondary like supporters of the shoulder, like the ligaments, aren't fully torn or too badly sprained or strained. And so that's why we don't have the standing orders to do it right away on the field, because most of the time we need imaging to figure out if he can move on to play. But if you have a chronic dislocator, or that person really wants to play after you reduced his shoulder, you can always check on his stability and his function. So if he's able to do his job without too much pain, or if the pain is, if the pain is like not letting him do what he has to do, basically not letting him function in the same way, so it's diminishing his performance. So the way we're gonna check, we're gonna start off with range of motion. First, he's gonna do active range of motion. So I'm gonna instruct him to flex his shoulder, extend his shoulder, and also you can stand if you would like, if it feels more comfortable. So he did flex, extend. He's gonna do abduction, adduction, and then he's gonna do internal rotation, external rotation at 90 degrees, and then he's gonna do internal rotation and external rotation. So that's good. So if he had any pain doing those, were you okay doing those? It was good? Okay. For active range of motion, he might experience a little pain because he's the one activating his muscles, but if he can push through it, then we can continue on. So the next one is going to be passive range of motion, and I'm going to be performing. So I'm going to move your arm up into flexion and down into extension. Is that okay for you?
Mm-hmm.
All right, and then I'm going to abduct the arm. Is that good?
Mm-hmm.
And adduct the arm. And then I'm going to externally rotate, internally rotate, and then we're going to bend your arm. And then we're going to externally rotate and internally rotate. All good for you? Okay, so the next one we're going to do is resistive range of motion. I'm just going to apply a little bit of resistance every time we do those specific motions. So we're going to flex your shoulder, okay? Flexion. Perfect. And then we're going to extend the shoulder. Go ahead. Perfect. Okay, so now we're going to do abduction. Go up. Perfect. And now we're going to do adduction and go down. Perfect. So now we're going to do external rotation. Go ahead. Internal rotation. And then bend your external rotation. Okay. And internal rotation. Perfect. Okay, so if his strength was pretty good or good enough for him to go in, then we would move into the special test. So we just went through the range of motion with Trace. He was pretty strong in all of his range of motions, but we want to check the special test, so the anterior stability, because a lot of times when you have an anterior dislocation, it hurts in the front part of your shoulder, near kind of the deltoids and the anterior part of the shoulder. So what we're gonna do is we're gonna have Trace lay prone or on his stomach. And we're gonna do what we call a joint play kind of test. And this is so awkward. Okay, so I'm gonna hold Trace's arm basically where his elbow is, and then I'm gonna grab him just right by where the head of the humerus is, and his as close to the joint as I can get. And then I'm just gonna put some pressure. And basically here we're looking for the laxity, kind of, or how much the humerus is moving forward, right? And then we're going to move on to our next test where Trace is going to move, he's going to be laying supine. So he's going to flip over. All right. And we're doing an apprehension test. So now we're testing all of the anterior, anterior stability, because it's very important that if you want a player or an athlete to be able to go back into the game, that they have stability and that they're able to function. Stability is the most important. Strength, of course, is important, but we want to check his stability. So we're going to do the apprehension test. Basically, the apprehension test is going to have him in this motion, right? And we're going to externally rotate his arm. I have my hand on his shoulder to see if there's any pain. Pain when we externally rotate? Yes, and apprehension meaning that you feel like it's gonna pop. Okay, yeah. So now we're gonna do, we did the apprehension test, we're gonna do the relocation test with the apprehension test. So we're gonna go back into that external rotation, and then we're gonna push posteriorly. All right, pain? Okay, so those are the two tests that you would check for the for an anterior dislocation after you reduce the anterior dislocation, we're checking for anterior stability. You do the apprehension test, which if it was positive, that meant that he had pain and apprehension, and he felt like it was going to pop back out. So you're going to do the relocation test, and basically the relocation test, you're looking for a reduction in symptoms. But since he had pain with both, then overall the test is negative. So if he would have said that he didn't have pain on the relocation test, then the test would have been positive. But because he did have pain, it's negative. Now, if you had a positive test or a negative test on the apprehension test, so we did the apprehension test. If you had a negative test, we would go into the relocation with the anterior release. So let's do that. So, pain? No. He said no, he doesn't have pain. So now we're going to do, so now we're doing the relocation test with the anterior release. So I'm in this external position with the posterior pressure on his humerus, and then, all right, so we released, we were looking for pain and for an anterior dislocation, basically. Good job, Trace.